But notwithstanding all the advancements in the area, the general practitioner is also what I would be chosen, especially on the individual patient is having comorbidities like chronic pain failure, chronic liver disease, and then he happens to be a very alcoholic intaker. So a lot of areas of interest are there, and I think we have got the most suitable person to address these problems. And that is what I brought in this house. Thank you.
Thank you, Dr. Raj, for the nice words. First of all, let me thank the organizers for inviting me for this academic program. And my topic is oral anti-diabetic drugs. But before going to the topic proper, I will quickly go to some of the historical background of diabetes mellitus. As you all know, the previously diabetes was considered as a disease of sugar only. But there are two types of, generally, two divisions. There is type 1 and type 2 diabetes. And we are more concerned with this definition. There is type 2 diabetes, that is part of metabolic syndrome. And by this definition, it is a disorder of multiple etiology characterized by chronic hyperglycemia, and in which, apart from carbohydrate, is carbohydrate, fat and protein metabolism abnormalities, and resulting that is due to the defect in the insulin secretion or insulin action hormones. And you all know the burden of diabetes is increasing day by day, and it's a lifestyle disorder, type 2 diabetes, so the mortality and morbidity is very high. And there are various forums. There is International Diabetic Federation as a slogan every year, but from 2009 onwards, there is a single slogan for 5 years. That is the patient education, that is diabetes education prevention. Being a lifestyle disease, the patient empowerment is more important. Go back to the history. The description of diabetes is there from various literatures, including India, that is from Susuda and Charega. And the name diabetes was coined by a famous Greek physician, Aretius from Cappadocia, that is around 150 AD. His description is melting down of flesh and meat into the urine because of the wasting. And the diabetes, the word meaning, the Greek word, diabetes, that is passing through or cycling. Mellitus means honey, which was later added by Sir Thomas Willis. His contribution is mainly in the neurology. Everybody we have studied in our neurology class, that is a circle of Willis. And 1869, Paul Langerhans, the medical student from Berlin, when he was examining pancreas with the microscopy, he first identified the islets of Langerhans. Claude Bernard is the father of physiology, who had its initial description about the pancreas and pancreas-inducing metabolism. And previously, the diabetes is considered as a disease of kidney because this due to the urine is attracted by the ants. So the first change is by the study by Joseph Van Marik and Oscar Minovsky. The role of pancreas in diabetes was first discussed by these two people. And there comes the 1921, the great discovery, the discovery of insulin by Banting and Best. And along with other two persons, that is Holly and McLeod, and they were awarded the Nobel Prize in 1923. And the birthday of Banting was celebrated as the World Diabetic Day, that is in November 14th. And other landmarks, other two Nobel Prizes in the field of diabetes is one is Sanger, that is who first discovered amino acid sequence, and Rosalind Diallo, the radioimmunase for insulin in 1977. and biosynthetic insulin 83, and pen delivery system in 1996, and the analog in 2000s. And let us discuss about the OHA, how the OHA comes to the field. That is in 1942 by an accidental discovery. That is during the Second World War, to treat the soldiers. There was no such medicine for typhoid at that time. And Marcel Janbaum is a pharmacologist. In that time, the experiments mainly on the animals like dogs. They were given sulfonate urea, and some of the dogs behaved in a bizarre pattern and some died. And on retrospective analysis, it is found that the blood sugar is very low. And there comes the introduction of the first sulfonate urea, that is chlortopamide, that was first in 1956 in clinical practice. And the Gelaga officinalis, that is a traditional medicine used in 20s to treat diabetes. This mainly the content is the guanidine, but guanidine is very erratic in controlling the diabetes, and more refined form in 1922, that is from the two molecules of guanidine combined together to produce biguanides. But at that time in 1922, the insulin is in the market, so everybody is behind insulin, so that was forgotten and reintroduced in 59. Metformin, introduced by Jean Stern. It's a French doctor, and the first one is the metformin, but now it is out of market because of its side effects, like lactic acidosis. Then glitazone. Before discussing about the glitazone, we should know the peroxisome, the molecular level, that is first discussed by the cellular biologist, the Belgian, that's Christian Dieu. He was awarded Nobel Prize in 1974 in the field of physiology. Then PPR gamma, there is a peroxisome proliferated activator receptor. It is by Isabella Eastman and Stephen Green and Stephen Cleaver in 1995 who introduced the PPR gamma agonist, that is the pioglitazone and prosiglitazone. And you all know the diagnostic criteria of diabetes. And from 2010 onwards, HbA1c also included as a diagnostic criteria in diabetes, that is more than 6.5. And pre-diabetic, it is the 5.7 to 6.4. And this is the common thing that we will face, including our children. That is obesity, and it's also in the adult also. That is, obesity is increasing day by day because, including me, I am not an exception. Everybody likes junk food. So people are eating more and more junk food, and the metabolic syndrome and diabetes is the next result. And to treat diabetes, there should be a teamwork, and patient empowerment is very, very important. And in natural history, all of you know, that is, we should not have any screening system just like Western countries. Well, we should have it because we are the capital of diabetes, and we should screen the people, at least those who are at a higher risk, that is, those who are having family history, sedentary work, and family history of gestational diabetes. And they should be screened at the age of at least from 25 onwards. It is yearly screening, so that we can delay the onset of diabetes. There are different modalities of treatment, that is starting from the cornerstone is the exercise and the medical nutrition therapy. Then various drugs are there. And we can start with exercise from the childhood itself, and medical nutrition therapy with the pre-diabetic, and the drugs according to the recommendation, that is once the diagnosis of diabetes established. But some people are starting early in the pre-diabetic age, pre-diabetic group itself. Coming to the topic proper, there are a battery of oral anti-diabetic drugs. The first group is the secretagogues, that is sulfonylureas, and another subset is the prandial regulator in the sulfonylurea group. They are meglitinides. It's not popular because they have to give each and prior to each and every meal. Then insulin sensitizers, there are two. One is predominant action in the liver, that is biguanides, that is the metformin. Then sensitizers, predominant action peripheral, that is in the adipose tissue as well as the skeletal muscle. They are thiazolidinediones. Then carbohydrate absorption inhibitors, that is alpha glucosidase inhibitors. Then apart from the conventional drugs, there are newer drugs are there. That is DPP-4 inhibitors, then fifth release bromocriptine and bile-acid proteins. This is not much popular. And various mechanisms of action in different levels for each and every oral hypoglycemic agents. We'll first go through the sulfonylurea. The first generation is not in the market now. The first one is the acetohexamide and chlorpropamide. Chlorpropamide is banned because of syndrome of inappropriate ADH production and disulfiram-like reaction. And chlorpropamide is withdrawn from the market because of it will interfere with the iodine uptake. The other drugs is familiar to you. The glibenclamide is the long-acting sulfonylurea. The main action is the mechanism of action is the ATP sensitive potassium channel. Then glipizide and gliclazide, they are short-acting. Glimepiride is a long-acting one. And the last one, that's gliclazide and glimepiride has an additional benefit over platelet that will prevent the platelet aggregation. So some beneficial effects in myocardial infarction. The dose of glibenclamide is familiar to all of you. That is starting from 2.5 milligram to 5 milligram. Maximum dose is 20. For glipizide, it's again the same dose. Gliclazide, the dose is the tablets are available 30 microgram, 30 milligram, the modified release, and 4880. Maximum you can give up to 160. Glimepiride, 1 milligram tablet, 2 milligram, and 4 milligram is available. Maximum dose is 8 milligram. Meglitinides, as I mentioned earlier, they are prandial regulators. That is ripaglinide and ecglinide, but you have to give each and every prior to each and every meal. Then biguanide is the most popular. That is the metformin. It is the first line of treatment irrespective of lean or obese diabetes. Previously it was thought that we have to start metformin obese and we have to start sulfonylurea in lean. But that line is already gone. It is, we are mainly concerned about the visceral obesity rather than the morphological. We have to start with metformin. Mechanism of action, there is insulin sensitizer, there is reduced hepatic insulin clearance. Then by inhibiting the gluconeogenesis and mainly acting to the blood one. That is a glucose uptake and transport molecule. Thiazolidinediones, they are glitazones. The proglitazone is out of market because of hepatotoxicity. The rosiglitazone also out of market because after the DREAM trial because of cardiac events. Pioglitazone still in the market. It's a very wonderful drug, but it has its own problem. Now it is more popularly using as the minimal dose, that is starting with 7.5 milligram, and most of the pharma people are starting with the low dose. That is 7.5 milligram, and you have to step up the dose. You have to maximum in daily dose is the 45 milligram. But it should not be given in patients with cardiac failure, and the major side effect will be the edema and hepatotoxicity and sometimes agranulocytosis, and some papers which have some controversy, but it's very, very rare. Then coming to the alpha glucosidase inhibitors, mainly acarbose, miglitol and moglibose, they are prandial regulators. They will act in the intestine. There won't be any systemic action. So it is one of the drugs that can be used even in type 1 diabetes as an adjunct. And they will act in the fresh body, the disaccharide, that break down, that's the carbohydrate, the monosaccharide, that level, that is sucrase, maltase, isomaltase. These are the enzymes block. And the HbA1c level, the reduction is roughly about 0.5 to 1% only. So usually not used as a monotherapy, the additional drug this is used. Then coming to the newer drugs, that is DPP-4 inhibitors, the drugs based on incretin therapy. There are three groups are there. One is the sitagliptin, then Bilda, now this laxagliptin. And a few words about the incretin effect. That is, when a person is given glucose or carbohydrate orally, take the insulin analysis. Or again, for IV glucose and again take the insulin assay. In a patient, those who have taken oral insulin, the amount of insulin production, with oral carbohydrate, the amount of insulin production is increased. That means something to stimulate in the intestine to promote insulin secretion by the beta cells. This effect is called infiltrating effect. That is mainly through two, that is GLP-1, that is a glucagon-like peptide, and GIP, that is a gastric inhibitory peptide, polypeptide, or otherwise glucose-dependent insulinotropic polypeptide, that is in the G cells of the duodenum. The glucagon-like peptide that is produced by the L cells of the ileum and colon. And this is a diagrammatic representation, that is that when the food enters in the intestine, the GLP-1 and GIP both are released and they will stimulate insulin by the beta cells, and the other hormone, that is glucagon, is reduced and slowing the gastric outflow, that is gastric emptying is reduced. So the rapid excursion of the blood sugar is minimized, then early satiety. So there is weight reduction can be achieved by this APP4 inhibitor. And another advantage is there won't be any hypoglycemia. There is one of the better effect of other drugs that can produce, suppose the dose is high, patient can have, especially elderly, there will be nocturnal hypoglycemia. For the newer product like DPP4 inhibitors, the nocturnal hypoglycemia is very, very rare. But the inhibitory factor in starting, the DPP4 inhibitor is a price. Patient had to pay. There is 3 tablets in cost roughly around most of the companies, that is 1,200 to 1,500 for this oil change, for a tedious dose. Otherwise, it's a good drug to be started early because beta cell preservation is one of the another advantage apart from there will be any apart from the hypoglycemia event. And this is only theoretical purpose. The insulin sensitizers, apart from oil chain, there is acyclovir has some effect, indapamide, and chromium, even coffee and dietary fibers. And just quickly go through some other therapies. That is SGLT2, that is a sodium glucose transporter uptake inhibition. That is a dapagliflozin. That is the reuptake of the glucose in the proximal convoluted tube is inhibited. But the FDA doesn't give any clearance because of incidence of bladder malignancy is high. It is again kept for review in this month, that is January and February for the ADA for the again for the approval. And apart from the PPR gamma, there are other alpha and gamma agonists. Various drugs are in trial, some in phase 1, some in phase 2 and phase 3. But not so far, apart from pioglitazone is recognized as a treatment. Because of various side effects, some of them are shown like edema or abnormal hepatic enzymes or tumors. These are some of them, but trials are going on. And coming to the other new drug in the market, there is a bromocriptine. Bromocriptine, you all know the treatment of prolactinoma, but the quick release form of bromocriptine is used as a treatment for the diabetes as an adjuvant therapy, not as a monotherapy. There is mainly in a small subset of individuals in which in type 2 diabetes the early morning hyperglycemia, because the early morning the hypothalamic axis, the dopamine level is less. So something to stimulate, to reduce the insulin resistance. So there comes the role of bromocriptine. The traditional formulation that is available in 2.5 that is not used. The quick release form is used. Then you have to start with the doses like this. Once daily, after 2 hours of waking, and initial dose is started 0.8 milligram, and you have to step up every day. Maximum dose is 4.5. That means you have to take 8 tablets of bromocriptine. along with others. Then the next one is and we are having only limited experience with chromography, and one trial is going on our department, and we have few patients on chromography. Then bilateral binding since we have no experience, that's called is cellular. The mechanism of action is acting through nuclear receptors. The Amrita people are doing this study. And the tablet is 625 milligram, 3 to 6 tablets prior to each meal. It's a high quantity. And it will produce hypertriglyceridemia. That's one of the disadvantages, and gastric disturbance. It can be used as an anti-dyspeptic agent. Even though it is not absorbable, it is acting, its postulation is to the acting to the nuclear receptors. And this is the treatment algorithm. Don't be get afraid of the algorithm. There is a treatment in the cornerstone of diabetes. One is the lifestyle modification exercise. Then comes, irrespective of lean or obese, we have to start with metformin. To a sufficient dose, gradually titrate. If not responding, we can add any drug OHA. Either sulfonylurea or glitazone or DPP-4 inhibitor or alpha glucosidase, even bromocriptine. If not controlled, we can add on basal insulin, or we can start with metformin. If not controlled, we can add basal insulin at granule. Or suppose you can go by HbA1c level. HbA1c level between 6.5 and 7.5, start with metformin and gradually step up and add on second drug if not adequately controlled. If HbA1c level is more than 7.5 to 9, don't start with monotherapy. We have to combine 2 drugs. Or metformin plus basal insulin. If HbA1c is more than 9, we have to start with insulin plus OHA if there is no contraindication. Because the higher HbA1c level or higher blood glucose level, there is a concept called glucotoxicity. Insulin receptors may not be acting properly, so we have to tackle insulin first. And we have to monitor the patient promptly in order to minimize or in order to reduce the incidence of acute complications like diabetic ketoacidosis or hyperosmolar non-ketotic coma or hypoglycemia. In a diabetic patient, it is considered as this unchanged equivalent. So hypoglycemia may lead to life-threatening arrhythmias. So we have to monitor it promptly. Then we have to prevent or delay the onset of both micro and macrovascular complications like nephropathy, neuropathy, or retinopathy, or macrovascular like myocardial infarction. So what are the goals we have to achieve? One is the fasting blood sugar, that is 70 to 130 milligram percentage. That is, again, in elderly we will go by higher. In this two, minimum is up to 70, that is without producing hypoglycemic event. Then 2 hour ppbs for diet control is 140, but in elderly we have to go up to 180. HbA1c according to ADA criteria it is to be kept less than 7, but the European Union, that is their criteria is 6.5. Then blood pressure, it is 130/80. This should be our target. Then LDL, that should be kept at below 100. But in a patient already had some cardiac event, should be less than 70. Then HDL target is more than 40. And in a women, pre-menopausal, the same value, but in a post-menopausal, should be kept above 50, the HDL value. Then triglyceride level should be less than 150. And BMI should be less than 25. And physical activity, according to WHO, the brisk walking, or at least 5 days in a week, that is up to 2 kilometers. But this should not be applied to each and every patient. That should be exercise pattern. We can modify according to the comorbid condition. In a patient arthritis, suppose you suggest brisk walking for 2 kilometers in every day, you will lose the patient, you will go to another branches of medicine or quacks. So you can modify and ask them to do the graded exercise according to his comorbid conditions. And there are various associations the bodies are the WHO, International Diabetic Federation, granting the various scientific programs, and this is the World Diabetic Day celebration. Our touch called the blue illumination. And we should work together. We have to maintain the reasonable, the